Tyler? Now he's sidetracked.
Right, now I can't think straight. So let's talk real quick about the flu. So far, I haven't seen much come across, but of course we expect it to come at some point. Every season we go through this, and it's always a good reminder to know not only what we should know, what we should be telling our patients, but also what to expect in terms of treatment. Who do we diagnose, who do we treat, and so on. So in general background, this is Dr. Khan's thing, and then this is the education we're giving our providers so that you know about this, because we want to come as a unified front in terms of who's getting diagnosed. We don't do flu swabs on everybody, and we're not going to treat everybody either. So you guys need to know that, so you don't tell patients, hey, we're going to do a flu swab, I'm going to give you some Tamiflu, and then we come out and say, no, there's no need for that. And then we come out looking like we're discordant, and that shouldn't be. So the background is, obviously, last season was really tough in terms of the amount of flu that we saw, but also the severity of illness, especially those of more than 65 years of age and less than 5 years of age. CDC has put out some clear guidelines, so should be tested, who should be treated, and so on, and we should kind of follow those in order to decrease the length of stay of people who are admitted for influenza, to decrease the amount of testing and the amount of treatment that we do, and also to limit the side effects of the Tamiflu, which are quite considerable. Limitations of the flu test itself is only about 50% sensitive, so it only picks up about 50% of the people with the flu, but it's 90% specific. So if it is possible, then it is influenza, and we're only testing for influenza A and B, and there's other kinds of influenza-like viruses that cause similar presentations, so we're not testing for every single one. Treatment, who should be treated? We said already kind of the very young and the very old. They're recommending less than 2 years old, but based on what I just said, people who are less than 5 years of age were kind of sicker and more morbidity. I would probably treat anything less than 5, more than 65 for sure. People with comorbidities, COPD, asthma, pulmonary disease, but also a whole bunch of others I wasn't aware of. Renal, hepatic disease, sickle cell, people with previous strokes or neurological disability, diabetes, anybody with immunosuppression, women, not only pregnant women, but also postpartum, and American Indians, Alaska natives, persons who are morbidly obese, and those from nursing home or facilities, so somebody going back to jail, nursing homes. I often, this is not here, but it's kind of my practice, a teacher who's going back to school, and there's plenty of kids, and I'll probably treat her too. What's the data about Tamiflu, and is it really effective? Well, the data is actually pretty poor. When it was published initially, there was very, you know, oh, it's wonderful, it helps, you're going to feel better quicker. And when they asked for the actual raw data to analyze it, it wasn't provided to these agencies until much later. By that time, Tamiflu was all out, and it being promoted as this cure for flu. The bottom line, what we know about Tamiflu is decreasing the duration of symptoms by 1 day. So if influenza lasts about 7 days, and you get about 6 days of illness instead of 7. So it's not a miracle drug where an hour later you're feeling better. Some people say, well, I feel better in a day. Well, that's because you were going to feel better, not necessarily because the medicine did anything to you. And of course, well, not of course, they actually evaluated the effect of Tamiflu in decreasing hospitalization, complications, pneumonia, and things like that, and they found no difference between the treated group and the untreated group. So in terms of the really sick, about being hospitalized or not, no difference. Which should be treated, hospitalization. So anybody who's getting admitted, you know, we're starting a SIRS and we're starting sepsis workup, all those people should be tested. And that's kind of what would be my practice. If they're sick enough to trigger a sepsis workup, then I'm going to start doing an influenza test with it. Because if you find they're influenza positive, then you kind of, okay, then it's viral. Not that you can't be sick with viral syndrome. I mean, you might be sick enough to need admission. If you have SIRS, that's systemic inflammatory response, whether it be from a virus or not. Now, people who have active viral syndrome can also be predisposed to a bacterial infection. So they can have superimposed pneumonia, superimposed something else, because their system's already fighting something else. So it doesn't mean you can't have both. And that's where it's going to be really difficult to say, well, it's just a flu, we shouldn't be doing all this. And my counter question to the providers is, why wouldn't you? I mean, last season or years before, I would send all these younger people with heart rates of 120s. Oh, it's just a flu. What if it's not just a flu? And if you admit them because it was just a flu and they get fluids and overnight they get discharged, so what? They get discharged. They're fine. You know, why would you run that risk? One thing I found that I learned is that Tamiflu only works within the first 48 hours of the illness. After that, there's no proven benefit of doing it. So if you're not going to treat, don't test. Having said that, if it's a teacher going back to school, I do want to test because if positive, then I can put her out of school and the kids don't get sick, that kind of thing. Or they're going back to a nursing home. And you kind of want to test because then you're going back with, this is influenza positive, they do precautions and things like that. But interestingly enough, if they're pregnant and they're outside the 48-hour window, you still do it. You still treat them because of the risk of morbidity and things like that. So this is just more of a practice guideline. They'll put it as our policy is not to test, our policy. There's no policy. It's just something we want to come out as knowing the data and what we're going to do. And the bottom line is Tamiflu is not been proven to be effective. And if it is, it's effective by 1 day instead of, so 6 days instead of 7 days. So if that's worth to you, remember Tamiflu major side effects, nausea and vomiting. So now you're sick and you're puking. And some disorientation, some other things, side effects. So just consider that also. And the cost. We're talking about a kid's dose. Last year I prescribed my son a dose and it was like $190 because he had to buy 2 bottles to complete the full dose and it was pretty expensive. So.
And one last thing for y'all go. Mark